clinicians, so the most important thing which people keep asking is, which is the T1? How do I identify the T1? How do I identify the T2? So that is simply done by looking at the fluid, right? All fluid is bright on T2 weighted sequences. So where do we look for the fluid? Look for the fluid in the ventricles. Look for the fluid in the cisterna magna. So you can see this is bright, the fluid is bright. So that means this is the T2 sequence. Then the area where the fluid is dark is the T1 sequence. Once you have identified which is the T2 and the T1 sequence, the next thing you need to remember is which is the pre and post contrast sequences. Remember that in radiology, most 99.99% of all the post contrast sequences are T1 sequences. We don't do T2 post contrast routinely. There are very specific indications. So then how to identify your post contrast sequences? Start looking at the vessels. Do you see the blood vessels here? They are black in color. But on the post contrast sequence, it is white in color. So identify the CSF. It is black CSF, but the vessels are white. This is post contrast T1. Okay. Another interesting point you can always imagine is the turbinates. These are the nasal turbinates. Nasal turbinates enhance well after contrast. So you can see the nasal turbinates are white here and black here. That is another way to identify the post contrast sequences. Right? So CSF and the nasal turbinates and the blood vessels. So that is how you identify. So can anyone tell me here what sequence is this, T1 or T2? Look at the CSF. Right, so that's T1 sequence. So when you look at this, we are now going to look at the normal appearance of the pituitary gland on a T1 sequence. So the pituitary, as you know, is a bipartite gland. It has got a larger anterior lobe and a smaller posterior lobe. The anterior lobe occupies 90% of the cella. Almost the anterior and central portion of the cella are occupied by the anterior lobe. The posterior lobe is always found in the midline. Between the anterior and posterior lobe, rarely you do get this pars intermedia, which is often atrophied in adults, but you may find it remnant as a small cyst in between the anterior and posterior lobe, which is called the pars intermedia cyst. Right? So what is important? Now this is the critical point. If you want to note it, you can note it down. The anterior part of the pituitary, note the anterior part of the pituitary is iso-intense to this globoid structure. What is this globoid structure which we saw? That is the pons, that's right. So it is iso-intense to the globoid structure on both T1 and T2, right? So that is important. And the posterior part of the pituitary, because of its virtue of storing vasopressin, is bright on T1. It may be bright or dark on T2, but the important point is it has an intrinsic bright signal on T1, which is called the posterior pituitary bright spot. Remember 2 points. Point number 1, it is bright on T1. Point number 2, it is located within the cella. Both of these points should be there. Point number 1, bright. Point number 2, it is located within the cella. Then you give the contrast. As you know, when you give the contrast, the infundibulum starts enhancing first, and then your contrast dissipates into the pituitary in a centrifugal pattern, and the gland nearly always shows homogeneous enhancement. So you have looked at the anatomy, the size, the signal of pituitary, and now let's look at the size. So the size of the pituitary varies with both age and sex. The average pituitary measures anywhere between 3 to 8, and I'm sure all of you know about this Elster's rule, where we measure the height of the pituitary gland. In infants it's 6 to 8 millimeters, and in late pregnancy and postpartum it raises even up to 12 millimeters is considered as normal. The second structure's size which is important is the size of the infundibulum or the pituitary stalk. The stalk is usually less than 4 millimeters in width, and it's usually narrower at the level of the optic chiasm and wider at its insertion. The stalk is usually centrally located, but we have seen cases where the stalk can be eccentrically or be deviated even in normal patients. So just because the stalk is deviated doesn't mean that it is abnormal. So we have looked at the signal, the size. The next one is the shape. So this is a very important point. So the normal pituitary gland, because of the virtue of the bony cella, which doesn't allow it to change its shape, consistently has a convex shape inferiorly. But the lateral and the superior surface of the pituitary is usually flat or concave like this. You can see it as a smooth margin, it is flat or concave like this. So it may have a variable contour because this area there is not is the suprasellar or the parasellar views. So I just want to reiterate the same structure, the structure here. What is this structure? Optic chiasm. So the carotid arteries, they are seen as black dots because they are flowing blood through it. Okay. So all pituitary scans are done with a small FOV centered around the sella with a high resolution images, and we always do a dynamic contrast scan. Why are all these sequences important? So pay attention to this. So we acquire a T1, a T2, a dynamic post contrast and a delayed sequence in our institute. We have a 3 Tesla and a 1.5 Tesla MR in our institute, so we use them both. So for the peak contrast, the most important thing you need to see is the posterior pituitary bright spot. On the T2 sequence, the most important thing I would like to stress is cyst. Cyst contains fluid, and fluid is dark or bright on T2? It is bright on T2, right? The third is the dynamic post-contrast sequence. So these sequences are nothing but continuous sequences which are acquired, acquisitions which are done at multiple time points, 0, 30 seconds, 60, 120, 180 seconds, and this sequence is used to detect the microadenomas. So each one has their importance. The final one is the delayed T1 sequence, which is useful to assess cavernous sinus, parasellar, and postoperative residual disease, and I'll show you a case where it was useful. We acquired this at 5 minutes. So this is how a full study looks. It looks quite overwhelming, but once you break it down into the type of sequences, automatically you will be able to come to a diagnosis. So the approach or the checklist, which I would say you should remember a snake. So S, 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 finally 2 C's, right? So signal, size, shape, stalk, supraparasellar, sinus, chiasm, and contrast. So you start looking at your pituitary images in this fashion, right? So this is the contrast sequence which I was telling. Here you are able to observe how the contrast diffuses into the pituitary. This is at 0 seconds. At 30 seconds, you have faint visualization of the infundibulum. At 60, the infundibulum becomes very bright and the pituitary starts enhancing more. At 180 seconds, the gland and the infundibulum both show homogeneous enhancement. And this is your delayed 5-minute scans where it automatically shows you quite a significant enhancement and homogeneous enhancement of the pituitary and the infundibulum. Okay. So people would ask us, where would you recommend the patient to go for a 3 Tesla scanners? Most of the times we are easily able to do the scan on a 1.5 Tesla machine, and it is pretty good. It is only if you have a very strong suspicion of a microadenoma and your initial 1.5 T scan is not able to show it well, then you can refer the patient to a 3T scanner, and then you may have slightly increased sensitivity to pick up subtle adenomas. So that is where we use both the machines equally. So yeah, we would like to start with the audience participation. So this is the first case, and this is the only case for which I have a history, because all cases which are referred to me don't have history. I blame the clinicians for this. Okay, so can anyone take it up? So first we look at the signal. So signal of the anterior pituitary. Is there an anterior pituitary? Can you see an anterior pituitary? Yes. So somewhere along the base of the sella there is something like an anterior pituitary. 2 points of the posterior pituitary. First of all, what sequence is this?
T1.
This is a T1. So the posterior pituitary, 2 points I told you to know. First point is it intrinsically bright?
Bright.
Yes. Is it within the sella?
Yes. Yes.
Done. So your posterior pituitary will be khush. Next we look at the size of the pituitary. Normally it should be quite big, right? I mean, you should see some pituitary tissue, but here the pituitary tissue is very much thinned out, right? Second thing is the shape. I said it should have a flat top, right? Or at least a slightly concave. Here it is very much concave, right? The next point you would like to see is the stalk. See, the stalk is coursing through the subarachnoid space and touching the pituitary tissue, which is flattened along the base, right? The supra and the parasellar structures. Is there any problem with the chiasm? Nothing. Is there anything problem with the cavernous sinus in the ICA? Fine, nothing. So then the contrast is showing homogeneous enhancement. So what is the likely diagnosis here? empty cella, right? So there is, the pituitary tissue is squished downwards, the infundibulum is able to touch, it is able to cross through, right? So this is an empty cell. It has no, we see it very often, it is very often incidental. It may be associated with some endocrinopathy, but most of the time it is incidental. So the stalk should terminate, that is important. The stalk should terminate at the base of the cella. Small amount of pituitary tissue is usually seen. If it is less than 2 millimeters, the thickness is less than 2 millimeters, you can call it an empty cella. If it is 3 to 4 millimeters, you can call it as a partial empty cella. Now look at this case, right? We start again with the first, which is what sequence is the first one? T1, T2, and this one is post contrast. You can see the vessels are enhancing. So we'll start looking at the anterior pituitary. How is the anterior pituitary? Is it similar to the pons, the signal on T1? Yes. How is the posterior pituitary? Is it bright and located within the cella? Yes. So your signal is satisfied, right? The size. Do you think this pituitary is normal in size or is it big?
Big.
It is big. So there is something abnormal. And you can see the shape is showing some superior convexity and it is touching your optic chiasm, right? Where is the stalk? If you notice, the stalk is not going through, it is just getting stopped here, right? And whatever this pituitary mass is, on T1 it is similar to the pons, but on T2 it is very bright. So what is very bright on T2? Fluid is very bright on T2. It is similar to the CSF, right? This is similar to the CSF. So the last sequence that you would like to look at is the post contrast. Do you think it is enhancing on post contrast?
No.
It is not enhancing. The normal pituitary tissue which is around this is enhancing, right? But this is not enhancing. So something which is nearly similar to the pons but very bright like fluid is a, and not enhancing, is a cyst. The most common cyst which you see in this location would be
Infundibular cyst.
That's what it is.
Cyst.
This is another case which is quite similar to the one which you have seen before. Just wanted to show you that sometimes your T2s may not be as bright as CSF, and within this you are able to see a small nodule, right? You are able to appreciate this nodule, right? Now this is compressing your optic chiasm, and on your post contrast you can see the rest of the pituitary is enhancing while this is not enhancing. So this is another appearance of a Rathke's cleft cyst. So the mass is iso-intense on T1, the mass is hyper-intense on T2, similar to the CSF. So we know it is a cyst, but there is an intracystic nodule. If you do spot this intracystic nodule, you are going to see it in 70% of the cases, quite a few number. So then it fits with a Rathke's cleft cyst, and the most important thing is it does not enhance on post-contrast imaging, right? So you do come across this case. Case 3. So first look at your anterior pituitary. So first T1, T1, T2 and T2, right? So the first, how is the T1? Is it normal? Your posterior pituitary bright spot is okay, it is located within the cella, your anterior pituitary is okay, it's slightly hyper to the pons, but otherwise it's fine. Your size and shape looks okay. But is there anyone who can point out something abnormal in this case?
Concavity nahi, convection.
I want you to pay attention to this image.
Concavity nahi, convection ache.
Yeah. Can you look at this image and show me if anything is abnormal? Yeah, so there is something suspicious here, right? The suspicion is in this location. The suspicion is in this location, right? You are able to see that there is a small convex bulge upwards. On this side it is not that much, in this side it is more. So attention, your antennas should stand up, and so the rest of it is fine. Your supraparacellular, your chiasm, everything is fine. So what would you do next for this case? What is the next sequence you would ask for?
Dynamic contrast.
So you would like to look at the contrast, right? So you would do a contrast. So the contrast here, it is a dynamic sequence. So if you are able to appreciate it, you are able to appreciate the infundibulum is enhancing, Subsequently the gland is enhancing homogeneously, but there is a small spot within the gland which is not enhancing. So you have your 30, 60, 90. So when you take your plates which come, the imaging films which are given, so each line corresponds to one time period. So 30 seconds, 60 seconds. When you see this in the 60 or 90 seconds that there is a small defect which is not enhancing, so just like this, the gland through the infundibulum, the whole gland should enhance. This case is something like this. There is a small area which is not enhancing at the same time as the rest of the pituitary. So what is the diagnosis?
Microadenoma.
Excellent. So that is a pituitary microadenoma which was sitting there, and now I think you will be easily able to appreciate the convex bulge which is there along the superior aspect, right? So most pituitary tumors, it's not just micros but macros also tend to be less vascular than the normal pituitary tissue. They appear hypointense as compared to the surrounding pituitary tissue on post contrast, and that is what we use to identify the presence of a microadenoma, right? It may deviate the infundibulum and it may cause superior bulge. So those are clues on the plane itself which you can suspect, and then you can go for the post contrast sequences. Now let's look at this case. Okay, this case, how is the pituitary gland? Like your this is the T1, T2s, and this is the post contrast. So you have this series here. The anterior pituitary signal, is it similar to the pons? Yes, the posterior pituitary is a little bit displaced. It is there, but it is there, right? The next thing you are going to look at is the shape of the pituitary. There is a bulge superiorly which is happening there. The infundibulum is located here, the chiasm is located here. This is indenting onto the chiasm. The paracellular regions are okay. Your both ICAs are similar in size, right? And then on your post contrast, the point which I want you to pay attention to is this little notch. If you notice on both sides of the pituitary there is a notch. This notch is because there is a diaphragm cella which I told you. So the pituitary is a soft tumor. When it goes through the diaphragm cella, it produces this little notch. And why it is important, you will see, right? So then this is more than 10 millimeters in size. What is your most likely diagnosis?
Macroadenoma.
Macroadenoma, right? This one, if you notice, is a much larger cousin of the previous one. So this is almost peanut-like big one. Okay, it looks like a snowman. So this is the snowman sign which you guys read in the book. Your posterior pituitary is still located. Okay, the size is quite big. The shape is a snowman shape. The stalk, I cannot make any comment on it. If you look at it, this has actually broken through the thin base of the cella and extending into the sphenoid sinus. Sometimes you can even see extending such large pituitary adenomas that they go into the oro and the nasopharynx and have been mistaken for a nasal polyp, right? Yeah. So then you can see superiorly what is the structure above which is getting compressed. So your optic chiasm. So I'm sure all of you would refer this patient for a perimetry. And more importantly, this one is extending into the paracellular regions and encasing the
carotid,
internal carotid arteries. But still the arteries are same size. And then here you have the normal pituitary tissue which is enhancing along the periphery. So this is another example of a macroadenoma. So they are soft tumors. Remember the snowman configuration. And they can have, when they become very big, they become heterogeneous with areas of necrosis and cystic change. Now this is another case. I would say this is another cousin of the previous one. So again, the signal characteristics, you can see the posterior pituitary is still located in the cella. The pituitary has got a convex superior configuration, right? You all agree with me. But on the post contrast, you do not see that notch which was being caused here. And the whole gland is enhancing. It doesn't have a differential enhancement like we saw in the previous case. So what do you think this is? Excellent. So this is a pituitary hyperplasia, and what you were looking at is called the hilltop or the mountain peak sign. So these are the causes for the pituitary hyperplasia. So the notch is conspicuously missing. Right. So coming to the next case, quite interesting. So look at the anterior pituitary. This is T1, you have your T2s and the post contrast. What about the anterior pituitary? Do you think it is similar to pons? Yes or no?
No.
No, right? Your anterior pituitary looks kind of weird. It has got a bright signal within it. Okay. I have kept this other image just to show you that the posterior pituitary is not absent. It is just pushed towards the parasagittal location. Right? On T2, this is having a very grayish appearance. And post contrast, you can't comment on the enhancement of this thing because it is already bright on T1, right? What this patient presented with sudden loss of consciousness. So what would the diagnosis be? Excellent. So that would be pituitary apoplexy. And so you have in the axial views, you get to see this blood fluid levels. So you have blood above, that is the methemoglobin, and then the hemosiderin settling down in the back. So this is an example of a pituitary apoplexy. If you see bright signal of anterior pituitary and you see fluid levels and you have a correlative clinical history, then you probably are dealing with the pituitary apoplexy. The seventh case, what do you think has happened here? Let us see if my teaching has gone in. So signal T1, T2 and then post contrast. So
pituitary দেখা যাচ্ছে না গো
what is missing? Correct. So the posterior pituitary bright spot is not seen in its place. Means there is, I cannot see it within anything within the cella. Is it ectopically located? No, it is not ectopically located. How much should be the infundibular width normally? 4 millimeters. So how much is it here? It is little bit thickened. So the most likely diagnosis? 505. So that is the only thing. So if you have understood this, then you have understood the anatomy and how the signals, how do we interpret the signals, right? So that is absent, infundibulum is thickened, and yeah. So I think I'm done with the times. I'll just show you 2 cases. So what is wrong in these 2 cases? Your posterior pituitary bright spot is there, but it is not located within the cella and it is located outside. And your pituitary cella is also so small. This is another case where it is ectopically located and you don't have your infundibulum or stalk. So the diagnosis would be your ectopic posterior pituitary and your stalk is absent. So it would be pituitary stalk interruption syndrome, which is associated with hypoplastic anterior pituitary, thin or absent infundibulum, and nectopic posterior pituitary. So these are the tough cases. Ma'am, can I take 2 more minutes? Yeah. So this case is quite interesting. Can anyone spot the problem in this case? Ma'am, you had only referred this case. So patient has got a macroadenoma. What I want you to pay attention to is, I want you to pay attention to the internal carotid artery. These are dissimilar in size. So I was dead sure that this side it is encased by the macroadenoma, so it's not changing in size. But on this side there is some other pathology which is there, and it is the fungal sinusitis which is going there and encasing, and it is narrowing. Pituitaries do not narrow your ICS. Right? Another one. This was interpreted as a pituitary macroadenoma by my resident. What are the problems in this case? If you notice, your diaphragma cella, the snowman appearance is missing, right? And again, once more, if you notice these 2 vessels, you can see this vessel is smaller than this one, right? Your constriction is missing, the cella is missing, and if you notice, the pituitary tissue is seen separately from this. It is hiding away here, and this has got a dural tail which is coming out. This is a meningioma, right? It is a meningioma. It is enhancing quite well. So yeah, so this last one, where is this lesion? Just tell me, where is this lesion? That's all. It's not arising from the stalk. It is not arising from the pituitary. The mammillary body is seen separately. Patient has inappropriate laughter. The moment I tell clinical history, so that's what it was at Tuberculosis. So final slide, if you want to click it, you can see this is how we interpret. Look at the gland, size, contour, signal, look for whether there is any expansion, look for the stalk, look for deviation or thickening. Always ensure that the posterior pituitary bright spot is present and within the cella. Look for the supracellar cistern, look for the cavernous sinus and the paracellar regions. So thank you very much for your kind attention.